professionals. Thank you.
Thank you.
Thanks.
We'll move
Thank you
ahead
for
for the
the
next presentation.
opportunity. Thank you, Rainier sir, Sujit sir, Ibrahim sir. It was always nice to listen to you.
Okay.
Thank you. We'll move ahead for the next presentation. It is about mental health aspects of breast cancer by Dr. Monika Thakur. Dr. Monika, please go ahead with your slides.
To introduce Dr. Monika Thakur, she is again did psychiatry nursing, then did her PhD in psychiatry nursing. Then she pursued her career particularly on psycho-oncology. She did her initial work on patients with breast cancer to study about their psychological aspect. Then subsequently she continued that research further, and her original work is published in Lancet Psychiatry, Lancet Southeast Asia, Regional Southeast Asia. It's an interesting paper. Anyone who is interested to go through and know about the psychological impact, particularly in the Indian scenario, can go through that article. Dr. Monika Thakur has several publications to her credit, and she is actively engaged in research work. Over to you, Monika.
Thank you, sir. Am I audible?
Yeah.
Yes.
Yeah, I'll be presenting from two parts, so maybe if there is any disruption, please let me know. I'm first of all very much thankful to Dr. Sujita Kumar and Dr. Reena and my professor who have actually put me in this field. So Dr. Sujita is the main person who has actually pushed me into breast cancer, and the journey started in 2015, and it is till now it is just going on, and every day I think one or other idea keep on coming to my head, that how to make it more robust and more better for at least for my country and for my people. So with that I'll start. I am associate professor and a senior researcher in behavioral and organizational sciences at valuemetrics.ai, and I was working with NIMHANS. I'm a alumna of KGMU, and right now I'm working on my own. So with this, I'll start. So the burden of breast cancer is increasing each year with 2.3 million new breast cancer annually. And unfortunately, the mortality of the cases is growing with 670,000 deaths each year. And it also makes breast cancer as the most leading cause of incidence as well as the mortality rate in the woman. And future projection shows that by 2040, new cases are projected to rise by near to 30 to 40%, reaching more than 3 million annually, with a disproportionate impact on lower and resource countries. As you can see this previous slide, the highest burden, although, is in a developed country like Australia and New Zealand, followed by Western Europe and then another Europe. The incidence rate is quite low in the Eastern Asia as well as Southeast Asia. And as you can see from this particular graph, there's a fourfold variation in the incidence rate, where the incidence is way higher in countries like Australia and New Zealand, while comparatively very low incidence rate in Eastern Asia. Although the mortality rate in Eastern Asia is comparatively more higher. From this particular graph, you can see that among Asian countries, the highest incidence is in developed countries like Singapore, Japan, and the incidence is comparatively lower in lower income countries. As you can see that there are two Asias, one with a higher income and one with a lower income. And in these two particular divides, we can see that higher incidence is in developed nations, while low is in the people with poor resource and poor income settings. So now when we see this, even though the incidence rate is very low in these areas, the mortality rate, because of poor resources and lesser accessibility to the healthcare system, the mortality rate comparatively increases. If we speak about the background for the global burden of breast cancer and mental health, so mental health impact up to 80% of the patients with, this is the pool prevalence although, of depression 38%, anxiety near to 32%, and PTSD 10%. But this is not only limited to this number. This particular number, in our particular study, we have found 48.5%, and in many of the other studies, it has gone up to 60 to 68%. Although in many of the studies, it has been as low as 8%. So maybe there is a disparity between how the people are evaluating, but the pool prevalence is around this. So psychological distress occur across the pathway, with start of it at the time of diagnosis, depression and anxiety during the treatment, fear of recurrence, which is pervasive throughout the survivorship period, and it is confirmed by one of our recently published study. So research suggests that high prevalence of mental health issues is globally reported, but most studies use Western designed instrument, which may not be able to capture the cultural variation, which is huge in multiple places. Now, the psychological journey of the patient is not starts at particular point and end at particular points. And generally, people, be it general people or a clinician or any other healthcare worker, they feel that once the person is diagnosed, there will be obviously some sort of distress, but it will go with time. And once the person is okay, then there should not be any kind of issue. But as you can see from my screen, that initial time of the diagnosis, there's 85% of any kind of psychological morbidity associated with breast cancer. And during the time of treatment, as people start using acceptance and also multiple other copings, so the rate of the psychological morbidity, although decrease, but once they come out of it, then the shock sometimes come into the picture. Although some positive result also comes, which is called as post-traumatic growth. But along with that, we can see that the rate again come back to 70%. So at the time of diagnosis, there can be shock, there can be fear, and multiple other crises like financial issues. At the time of treatment, depression comes in, anxiety comes in, financial issues are huge, the caregiver burden increases a lot. At advanced, at end of life kind of patient with metastatic recurrence, there is anxiety, the fear of death, and family distress is huge. And at the time of survivorship, the fear of recurrence is as high as 70%. In our studies, we have found that there is 90% of the individuals who are suffering from fear of recurrence. So that means even though they are treated, although the treatment is going on, but it doesn't mean that now everything stops. It keep on going. Untreated consequences. What happens when you do not look into these patients, when you do not look into these cases? So in the initial period, what studies have observed, this all are research related data. At 0 to 6 months, 40% lower adherence rate is found. And in one of the study which is conducted in our center only, that have shown that people who are diagnosed, say in 2025, they will start their treatment post-diagnosis 2 years. That is the median rate. And this poor adherence is something which is alarming, because then patient can get changed into a second stage or the late stage, or maybe cancer may be further worsen, and increased side effect, higher hospitalization, and family strain. These are the major thing which happens during initial period, which is you can correlate with the uh, early diagnosis of the patient. Then in 6 to 24 months, we have seen that there is decreased quality of life, isolation, and in 2+ years, 20% higher mortality rate we have observed, and suicide risk is 2 times higher than the general population. And the cascading effect is there, which is of course among the breast cancer patient is there, but the people who are caring for them. And in a country like India, where the social system and the social family structure is still intact, there the burden becomes quite high and quite difficult to cope with. And even the one of the issue which one of my mentor have observed is collusion, where people sometimes the caregiver is not informed about the diagnosis, and many of the time the patient is not informed about the diagnosis, specifically with the illnesses which are terminating, or any sort of terminal kind of illnesses which might threaten the person or may give any sort of distress to the patient. Now, question is what makes them vulnerable? One is female gender, and then age. Female gender is something, the higher incidence rate, although we observe in the female, so that's the reason that they are more vulnerable to develop depression or any kind of illness. But few months back I was watching a series on Netflix, and I happened to come across a actor, and he in that particular series was diagnosed with breast cancer, and it took him more than 1 to 2 months to accept that, and to that he is diagnosed with cancer, and that too with breast cancer. And his sentence was, I do not have breast, how I can develop breast cancer? And most important part, which was more disturbing for him, was how he will go to a setting where majority of the patients are female, and how he will get the treatment. So starting from the diagnosis, how the diagnosis starts and how the treatment comes. And he was much more worried in that particular place, that how he will tell to his colleague that he is suffering from breast cancer. So the person who was a female, she was having benign tumor, she was the person who was helping him to cope up with these all things. And instead of him, she was going there as a patient, while in the treatment room he was getting the treatment. So, and then the body image issue comparatively hit him more hard than the female. So that means we need to change our lens a bit, and also need to evaluate, although very less sample we'll get, but something we'll get. And we need to evaluate even male counterpart, that whoever are suffering from breast cancer. Incidence is less, but it doesn't mean that they do not have any problem. Maybe they will have double the problem what comparatively a female is having. Age is the another reason, because nowadays what I've seen over past 10 years, that now younger females as young as 25, 26-year-old are getting diagnosed with breast cancer, and mastectomy, complete mastectomy is happening for them. So the future concern are increasing. So that's why age is the major reason. Other particular reason which we have found through multiple research studies of our own is treatment modality impact the person's prevalence of any sort of psychological morbidities, post-treatment effect, financial exhaustion, long-term treatment, less or distortion of the symbols of femininity, which is prime importance for the female. Then loss or distortion of the symbol of femininity, relationship problems, living with the uncertainty, whether I live or not live, whether the cancer will come again or not. So this particular slide will represent the data which we have collected over a period of time. I'll just try to brief it. So we have found, this is the first longitudinal study which we have conducted in our center, and it has shown that post 2 years after treatment completion also, the prevalence rate, although decrease, but there is not much a decrease in the sample size. So here we have seen that 90% of the patient having highest recurrence rate, and it was more in the younger patients. And other study, which is slightly associated with my topic, but I would like to put it in the picture as many of the medical health consultants are sitting here, that we have conducted a study, which is a very, very common topic, already conducted so many times, assessment of the knowledge, attitude, and skill about breast self-examination. And this we compared between medical students and the non-medical students. Although the difference was slightly more better with the medical student, but the numbers was not speaking as high as it should. There were 80% of the females who were not practicing breast self-examination, although they were from medical field. So multiple kind of attitudinal barriers are there, practice barriers are there, even among the medical stream people. So if the medical people by ourselves, we are not doing that, then how we will teach the other generations, other people who are coming from the general background. So this is a main point, I think, which we need to consider. Now, anxiety and depression study, over a period of time, it has shown that breast cancer survivor in Indian context suffer from multiple issues like fear of cancer recurrence, physical side effect of treatment, financial concerns, and many other things. And another one data shows that culture is of par importance along with the social support and spiritual coping in Indian patients. This particular study, this is slightly different from what we generally study, the negative part of breast cancer. This is a post-traumatic growth. So although the person goes through multiple adverse event during the entire treatment, but what happens post-treatment, many of the patient come through a very harsh period, and when they come out, sometimes they come with some level of growth in them, like personal strength, spiritual growth, social support, and many others area. So although multiple negative outcomes are there, but we have the chance that if we give a proper coping, if we give proper psychosocial intervention during the treatment time, then chances are very high that patient can come up with post-traumatic growth also. And then body image disturbances is something which I have found in my population study is very, very high. And it is associated with young age, more distress, type of treatment. Modified radical mastectomy is the main modality of the treatment, which is associated with body image disturbances. Another study suggested that unchanged anxiety and depression status, even post-treatment completion. And body image disturbances was prevalent in more than 90% of the patient, which is a huge, huge number. And we need to make certain efforts in this area so that those people and the difficulties with what they're living, we can treat them and address them. And one of the study which is published, this is something which is going to be my core area for the upcoming few years, that there is an inflammation and depression are associated with bidirectionally. So if you give psychosocial intervention, there are chances that inflammatory marker of the cancer will reduce, and it is already proven in one of the randomized controlled trial, which is conducted for 5 years in one of the Western studies. So these all studies again go onto the similar kind of issues, that basic psychological need of cancer patients are not addressed, and patients when they are diagnosed with the breast cancer, they go in the shock and denial. The prevalence of depression, this is our initial study which show a prevalence of 47.05% in the women who are diagnosed with the breast cancer, and the majority had although mild depression. And depression is found to be associated with poor coping. And in Indian population, we have found that religious coping is something which people accept the most, while the substance abuse and other kind of copings which are maladaptive, they were used comparatively less. So now, when a person go through this entire traumatic journey, the person doesn't go alone. There's a family and the caregiver involved. So now what kind of issues they are having, and what kind of issue they have to suffer from? There's an emotional burden, there's a support system, and long-term effect, and the overall impact. In emotional burden, the people go through collusion, distress, anxiety, depression, financial stress, role changes, uncertainty, partner anxiety peak during the treatment. And along with this, I also want to add one of the core issue which is very less addressed across globe, which is the sexual dysfunction and the partner intimacy, which is yet not addressed in research or any other way, although it is addressed, but very, very less. And support system, family-centered interventions are very less, although wherever it is completed and researches are done, there it has been proven that they are much better to bring better outcome in the patient. And in the long term effect, what we have observed that sustained mental health issue, persistent anxiety, depression, social isolation, physical deterioration, and children show behavioral problems. And this here only I would like to point out that the children have different kind of mind, different kind of way of looking at the thing. And one issue with the research data is very research data have looked into the psychological issue or psychiatric morbidities among the children. From India, there is one particular psychiatrist who is looking into this area, but otherwise, if I see in totality, the data is very less. And overall impact, we can say that the needs are unmet. In 50%, 25 to 30% caregiver depression, 2.5% higher than the general population suicide rate, 80% impact on the outcome. Now, this is the critical research gap which we have found, and we have tried to compare it with Western context and the Asian and Indian context. In the Western context, tools are available, but not always diverse. RCT exists, strong evidence base is there in the Western context. Growing telehealth and online tools are developing and continue to work in this area. And well-developed psycho-oncological integration and the consultation liaison psychiatry is there in the Western world. Increasing survivorship data is also available as the data is mature, so longitudinal studies are also possible for them. Caregiver and pediatric group addressed in the research. When we talk about the Asian and Indian context, what we see that few culturally adapted tools are available, validation urgently needed, and we need to develop the tools which are language specific, region specific, cultural specific. And this I have personally faced so many times where I have asked a question to my patient that do you use TV for your leisure? Then my person have replied to me that I do not have TV at home. So I do not know what answer to mark for that particular question. So we need to develop the tool which are easily applicable for our population, be it Indian population or any other population. And language is a very, very core important part of that. Models of Indian research lack robust evidence. Family-centered care is underused. Limited access is there, so that is why two-thirds depression cases are untreated. Evidence mostly are Western, limited local policy frameworks are there. Asian psychosocial outcomes are understudied. And maybe people are studying, but they are not published. They are not, present in the research platforms as such. Caregivers and pediatric cancer group face unique challenge, and we need to have a different kind of approach and a different kind of psychosocial intervention for them. This particular research gap in the priority area, how we can fill this gap, and what are the areas which we need to look for. So cultural tool validation is something which have the highest priority, and we need to focus on the low and middle income country cancer patients, and we should try to achieve it by 2026. If not that, then by 2027. Family intervention RCTs, that is also in the high priority. Family-centered care model lacks robust research, so we need to, supplement that with the descriptive, qualitative kind of research, and diverse caregivers should be involved in the studies. And randomized trial is something which can be used to get this kind of data and to implement psychosocial intervention. By upcoming 3 to 4 years, we should be able to achieve that. Digital mental health, as in India, there's a revolution going on in the digital platforms and digital kinds of work. So I think when we collaborate it is going separately. It is going in psychiatry, it is there in the medicine. But what if we combine it and we take patient into account? So the people who are sitting miles away from us, and they do not have active kind of financial support. So for them, when we provide such kind of technology through telepsychiatry, maybe telepsycho-oncology, through any kind of department, and it is unfortunate to say that digital mental health is very, very accessible, but still it is not available even in the major healthcare system which are there existing in the India. And although they are using this particular technology, but somehow we are lacking and we need to improve in this area. And I hope that by upcoming 4 to 5 years, we'll be able to do that. And policy implementation is something which, is making us actually go behind. So we need to, show robust data. I have focused on descriptive study so far. Reason is, my mentor told me initially, if you need to bring some changes, you need to have data. So we are creating data to show that yes, these people are suffering and we need to, provide something to them. So when those kind of policy changes happens, then, maybe we can make some changes in the health system. When we compare Western and global context and Asian context, what is the difference? So routine screening is the part of the standard care, while in Asian context, it is slight irregular and sparse. Multidisciplinary integrated team are there, while here urban-rural disparity is there. And because of workforce shortage, somehow the integration between the team is happening. It will take some time, but still not in as established way as it is in the Western world. And one more important thing, we need to look each person and each culture and country also with a different kind of lens, because for each person, same shoe doesn't fit. So strong CBT model has been have shown a much better result in the Western world, while yoga, meditation, spiritual copings are preferred in the Eastern world. Insurance coverage widely available, while it is limited coverage, but in India that's the one of the best part, that even though you do not have health insurance, you can go to a government hospital and can get admitted and you will be treated fully, and at you do not have to wait for say 10 months or 1 year. So there I think we are doing slightly better than maybe other places, if I'm not wrong. So lower stigma is there, a higher uptake of services is available by the patients and by the healthcare people. Here, higher stigma is there. Many of the time I told my patient that you have depression and it is severe depression, you should go and see a psychiatrist. So my patient caregiver directly told me that no, we just need to take cancer. She's not mental. So these kind of stigma, if get reduced over a period of time, it will be a plus point for us. And family on a concern is something which comes sometimes as a barrier. So lost control therapy is something which is helping for the Western people, and for us, family support and yoga have given the strength. So bridging the gap, as I told you, that screening tool is most important for the cross-cultural validation and adaptation, increase scope and duration of the psychosocial studies in Asia, engage more diverse patient samples to reduce the Western bias, and probably using our own tool and developing our own tool, design and evaluate new intervention for the family and caregiver, integrate psychosocial services into routine oncology practice, expand survivorship support to address long-term mental health needs, even though the patient is treated. But we cannot assume that person is fine. We have to provide our services even beyond the treatment. So this, as I already explained to you, but this is a very good model which have suggested that two particular intervention were very effective, and it has shown that CBT has the strongest kind of effect, while among the healthcare people, nurse support was much more effective for the strong health promotion. So here, I always, advocate psychosocial intervention. But why this particular one? Because she have studied medical health. She has studied cancer. She has studied pharmacology and each and every part what a cancer patient go through. And at the same time, she has studied psychology and then sociology, at the same time psychiatry. So when these kinds of things are there at her basic level of curriculum, I think she can be the much better person to integrate psychological care among the cancer patient, and they are by default present in the cancer wards and in the cancer hospitals. So why not to utilize such resources which are already available, and in the settings where already we have poor resources, so use what is already available rather trying to bring more people. It is good if we bring, but until then, and already it is proven by these many studies, and it is a pool prevalence which has suggested that CBT is very effective. At the same time, nurse support is something which have a stronger impact on the health promotion. And this is very clear that each country and each region need to adopt intervention which are suitable for them, which are suitable for their population. If I'm developing some tool, it may not be necessarily will be well adapted by the Western population. So we have to focus on what we are good at, and other people has to go their own way. Now, the cultural part I have spoke already a lot, so I think I would like to skip this particular part. But family-centered model and individual autonomy should be focused. Traditional modern integration, if we do, then we can bring a huge change. What we are not able to bring so far. Not only I'm talking about India or any Asian country. I'm talking about the with the global perspective. So, what we can do, the mental health action plan of WHO, which is from 2030 to 2030, universal health coverage requirement is there. Right-based mental health approach is required. National cancer policy mandate is important. International cooperation is essential. So when we see how we can do this, the key element is right-based approach with the global policy framework, national cancer policy mandate, international cooperation, and at digital and technological innovation level, mHealth apps, telemedicine, VR therapy, AI-powered screening tool, online peer support platforms are required with digital health integration. Workforce and training competency is very, very important. So we have to train the people in psycho-oncological care and skills. At the same time, we have to right now see who fits best and develop a standardized curriculum so that people have a good knowledge about both the sides, so that then they can integrate the care in a much better way. And country level best practices. So there are many countries which have proven themselves with best of best intervention, and we can learn from them and we can implement that. And as this particular model I have developed, this what I feel that if we go layer by layer and we start developing, starting from the WHO implementation policy only, layer by layer we can go, and level by level we can move ahead. And the places like Singapore, Netherlands, UK, they have already tested it, developed it, so we can learn from them and then modify it according to our need, and post that we can make the changes and can grow ahead. So now, call to action, what we need to do. So the data problem. So here we need to focus on the untreated cases, and less than 40% low and middle income countries have validated psycho-oncological tools. That means we need to focus more on this. Greater than 80% research from the higher income countries, which is cause a Western bias. Limited longitudinal data in Asian population is there, and even the survivorship data. And scarce empirical evidence on the family-centered care is there. Now, strategic priorities and solutions are integrate screening in cancer care protocol, develop culturally adapted intervention, established family support, create a sustainable financing mechanism for the people. Although in India it is there, the people who are below poverty line and who have certain, so many schemes are there, and people are fortunately are able to access those schemes and are able to come out of this threatening illnesses. And we have to build some international network so that we can come with a better plan. At multi-stakeholder level, we need to actually go to this area in a much better place. So for this, one thing one arrow can hit, I think, multiple places. That is research, data, and interventions. So policymaker, they need to mandate the integration of psychological care, psycho-oncological care, or routine screening. System need to implement screening protocol. Provider need to develop psycho-oncological skills. Researcher need to prioritize cultural relevance. Patient and families, they can advocate for the access. So the
Dr.
conclusion
Monika,
of my
just a minute. I believe your time is up. Can you please go ahead faster?
I'm concluding. Yeah.
Yeah, thank you.
The conclusion is that mental health is integral to quality cancer care. Cultural competency ensures interventions are relevant and respectful. Family-centered approaches strengthen coping and improve outcome. Evidence-based solution must have move more research into real-world practice. Every patient everywhere deserves competent psychosocial care. So, ultimate outcome of my particular research is we should not leave a single patient who is suffering from this kind of illness, and they should have access to basic psychological care, and they should not be crying, because the first sentence which hit me very bad was that you are the first person who have asked me how I am. Everybody is asking which treatment, what kind of surgery we'll do, but nobody have asked me that how you are feeling. So, with that note, I would like to thank you.
Quite an excellent presentation, Dr. Monika. I would like to invite any questions and comments from the audience.
Excellent presentation. Actually, we are running late, so we can take 1 or 2 questions maximum.
Can I ask you, how frequent is that people have this growth and adaptation, or is it something which is permanent, or is it changing? So I would expect, let's say it that way, I'm seeing something very similar in people with multiple sclerosis, that they sometimes adapt and they get very strong, and sometimes find their more or less they think they take life more easy, or change their view to life if they have a disease like this, even though it's unpredictable. And there's also this permanent anxiety of relapse. But the question is this something which changes all the time, or do you have some people who are stable in this assumption? I don't know. Can you clarify that?
Okay, so if I understand your question rightly, so it evolved over a period of time. When the diagnosis come, at that particular moment, the patient's fear and concerns are totally different, and they are in shock. So it is very difficult for them to even think about how to get the treatment. So in our setting, we get very late the patient very late, so the disease basically worsen up, and then it is very difficult to treat. And when we grow over a period of time, yes, many of the patient even grow stronger, and they accept the illness. And we have seen in our setting that many of the patients, while they when we ask them about their mental health, many of the people cry, but at the same time people say it is something which is given by the god, and the god will help me to strengthen it up. So people use multiple adaptive kind of coping strategies. So the people who focus on the problem focus kind of strategies, those people cope better. And then I think over a period of time, when they get to know that this is the part of them, and they have to treat it, and many of the time even family support is a major key area who basically support them. And many of the women, although they don't want to take treatment, but when they look at their children, and they feel that I have to do something for them. So these all factor, a strong family become in our setting at least a major pillar for them. and then they grow over a period of times. Many of the women in Western studies, we have observed that they start a new career. They completely change the perspective of the life. Some start with a new possibility. But in our settings, a majority of the female were non-working. They come from the rural background. So there the newer possibility was comparatively less. But we have seen multiple changes, in the growth of the spiritual side, and people start appreciating their life more. They start giving more care to them, and they start getting involved more with the family. But yes, it's a different kind of continuum. It keep on changing with respect to what factors are impacting them and what kind of support they are having. And personal coping, of course, I have seen in my last 10 years impact a lot. Acceptance is the key for a better treatment and better mobilization to all kind of issues.
Okay, thank you.